It's my pleasure to introduce Dr. Madeline Hicks from the Worcester Recovery Center and Hospital and an associate professor of psychiatry in our department, who will introduce today's speaker.
Hello, it's my pleasure to introduce our speaker, Dr. Eve Valera. Dr. Valera is director of the Valera Lab in the Psychiatric Neuroscience Division of Mass General Hospital. She's also an associate professor at Harvard Medical School and a research scientist at Mass General Hospital. Dr. Valera's research is groundbreaking. Hers was among the first studies to look at the prevalence of traumatic brain injury and its association with cognitive and psychiatric difficulties in women who had experienced intimate partner violence. She was the first to use neuroimaging to investigate brain connectivity along with cognitive function in women who experienced head trauma as part of their partner violence experience. Dr. Valera was awarded the Robert D. Vaught Founders Award by the North American Brain Injury Society. In addition to her many publications and speaking engagements to the academic world, internationally and nationally, Dr. Valera has translated her research on the effects and the presentation, both which can be subtle, of brain injury in women who experience partner violence into education and training for police, for judges, and for ER clinicians who work with women in the aftermath of violence. We're very fortunate today to have Dr. Valera speaking to us about Overlooked Concussions Plus, examining the intersection of intimate partner violence and acquired brain injuries. Welcome, Dr. Valera.
Thank you so much. Can everyone hear me okay? I think I'm mic'd up and stuff, so I think I'm okay. Thank you so much for that introduction. I really appreciate it. And thank you so much for having me. Thanks to UMass for inviting me and allowing me to give this presentation. I'm very passionate about this. Anyone who knows me knows that I will talk to this about anybody who will listen, because I think it's so underappreciated and misunderstood. So with that said, I want to say I have nothing to disclose, except one thing I will say is I don't sugarcoat things. And this is not an easy topic. I can tell you I'm looking at a room and I can't see all of you who are online, but I am absolutely certain that some or many of you have experienced some type of physical or sexual partner violence in your lives by the numbers alone. So I know that's the case, even if others don't know it, or even if you haven't told anybody. So I know I'm speaking to some people who may have experienced this. And sometimes it's triggering to people. So if you do find that it's more disturbing than you thought, certainly sign off, or if you're in the room, leave. And if you are here and want to talk to me afterwards, I'm available and happy to chat and discuss anything with you. So just a little disclosure that this isn't going to be a Peanuts comic grand rounds. So I just want to start first with giving you an example of somebody, the women that I work with. Am I okay?
Okay,
oh.
You're okay. There's people in the room.
So, oh,
I'm sorry about that.
No worries. Thanks for
You'll be okay.
catching that.
Yeah.
So I work with women that a lot of people don't understand, and many people never hear these stories, or they have misunderstandings of what a woman who's experienced partner violence may look like. And so this is just an illustration of one woman who approached me after reading my work and realizing what had happened to her. And we'll call her Lily. That's not her real name. But she was a woman. She is a woman. She wasn't in her 40s when she approached me. Now she's a little bit older than that. And she told me of her ex-husband who isolated her, did not let her leave the apartment, smashed her head against doors and walls for no reason, chased her with a shotgun, strangled her, causing petechia, the little red dots that you may see on people's face that they would talk about in CSI and stuff like that, as burst blood vessels. And he made her lie about it, or he may ask her, or the EMT may ask, did your husband do this to you, when the husband is looming over the gurney? So of course she's not going to say yes. He shoved and kept her head under water on several occasions and threw her off of their porch onto hard, dry clay. This is not even the worst of what has happened to her. 2 to 3 times a month for about 1.5 years, she would experience being quote unquote woozy from abuse, would wake up from being strangled. This happened about 10 times. In high school, she had the reading comprehension of a senior in college, so she was clearly quite bright. And now she found herself sounding out words because they were not making sense to her. And she said she had to go to the dictionary for words she had quote unquote read a million times, and it scares her. She had terrible word finding difficulties, forgetting names of people she knew well and had a relationship with, forgetting trains of thought when talking to others to a degree that was extremely disruptive, because I think that happens to all of us at some point. And she had anxiety and panic attacks for no apparent reason. She was currently in a very loving and safe relationship. So she couldn't figure out what was going on with her and why she still had so many problems. She said, I am absolutely dementing. Something is going wrong with me. And then she read one of my articles and she was thinking, oh, this problem, check. This is exactly her words to me. And it was a sense of relief because somebody had finally recognized what was probably going on with her, that she was experiencing the sequelae of repetitive brain injuries from partner violence. And she has now basically transformed her life in a way. She's so much happier, engaged and everything. And partly just that recognition and then tweaking certain things in her life to help her once she understood this. Okay, so what is intimate partner violence, or as some people say, IPV? IPV, simply put, is violence perpetrated by a current or former spouse, partner, significant other, boyfriend, or girlfriend. It does not have to be within the home. Okay, it can be for a brief amount of time. It can be anyone you're having an intimate relationship with. And domestic violence is a slightly broader term, which can include child abuse and elder abuse. So here we're just talking about intimate partner violence. Some really unfortunate facts about IPV it's the leading cause of homicide for women globally. If someone were to tell you that that woman was murdered, who do you think did it? Your best bet would be her current or past partner, okay? Because that is the most likely scenario. It's also the most common form of violence against women globally. So if you think about this, someone was worried about when we were walking through the streets of Chicago last week when I was at a conference. And I go, well, actually, as a woman, I'm probably safer out on the street than I am in my home, statistically speaking, right? So it doesn't mean I should be stupid, but the bottom line is if you think of it that way, it's yeah, this is really a problem that women are not safe in their own homes. And it's all found across all socioeconomic boundaries. Doesn't matter if you're rich, if you're poor, if you're Black, if you're white, if you're Asian. There are disproportionately affected populations for sure, but it does not spare anyone. So IPV is, I like to say, and really is truly a global public health epidemic. Technically, the term epidemic is incorrect because it suggests that there's a spike and it happens, then it goes away. It's really endemic, but I don't think that hits the point. People hear epidemic and they hear this is a bad thing. You hear endemic, it doesn't seem as bad, but it really is endemic. And it is, at the same time, sort of a crisis and a serious public health issue. So what are the numbers? Well, globally speaking, estimates show that 1 in 3 women experience some type of physical or sexual partner violence. That's a high number. And so I just want you to get a better sense of what this really means. I'm pretty sure there's 9 women in here, and I bet most people here know at least 9 women. So I would want you to think not which one, not which 2, but which 3 of those people may have experienced sexual or physical partner violence in their lives, because those are the odds. And you will not necessarily, you can say, oh, I don't know anyone who's experienced partner violence, because it's stigmatizing. People don't want to talk about this. People don't walk up to a party and say, yeah, by the way, my husband beats me. People don't talk about it because it's not accepted. And they're also, even if they want to talk about it, it's not socially acceptable necessarily to talk about it, or they're afraid they're going to offend somebody if they talk about it. Either if I ask you about it, I may be offending you, or if I tell you about it, I may be offending you. And we've got to change that dynamic. But the bottom line is, why am I saying it's all over the place? Well, because it is. But the other reason is because I want us to feel more engaged in this problem. These are not those people over there. These are our daughters, our sisters, our mothers, our partners, our friends, our colleagues. Just because we don't know it doesn't mean it's not happening. Unfortunately, in intimate partner violence, 80-90% of injuries to women are to the head or neck. I've had people tell me about getting stepped on the head with work boots, punched in the head repeatedly with fists, more than once, hit in the head with hammers, and whacked in the head with baseball bats. I'm not saying this to be sensationalistic, and this is actually not even the worst that I've heard. But if you look at these things and think that this happens to women who are experiencing partner violence, it seems like obvious that they're sustaining brain injuries or that they might be. Yet this is not a big area of research, right? This is not the NFL, right? Where we have leagues of researchers and tons of money to devote. There's a handful of people in the world studying this topic. So the bottom line is we know very little, but I'm going to tell you about what I have discovered in my own work. So the other thing that is very notable is that people who experience partner violence historically, before we ever talked about brain injury, report high rates of cognitive, physical, and emotional problems. And anyone who knows about traumatic brain injuries or post-concussive sequelae of traumatic brain injuries will look at this list and say, wow, that looks a lot like post-concussive symptoms. And it does, because it is, right? So what we see in women who are experiencing partner violence is often very similar to what we see in individuals who've sustained brain injuries, but we have historically always attributed these problems to women being hysterical, right? Oh, they're just psychologically maladjusted because they can't get out of this relationship. I don't know why they don't just leave that relationship, because they should just leave, right? Things that should never be said. But these are the types of stereotypes that women who are experiencing partner violence have to live with. So now I'm going to talk about TBI, because I just mentioned that those are symptoms that look like sequelae of a traumatic brain injury. What is a traumatic brain injury? Really simply put, the simplest way to put it is it's external force to the head and disrupted brain function. So basically, if you have a hit, a jolt, or external force to the head, that results in any loss of consciousness. So if you get a hit to the head and you're out for a second, that's a concussion. You don't need a brain scan. In fact, a brain scan is going to look like you didn't have any trauma to your head. That's a concussion, though. You don't need to do any further investigating. If you have a hit, jolt, or external force to the head, and you have any loss from memory events immediately before or after that incident, now there could be substances, that's a different story, but let's just say this is, from that jolt to the head, you say, well, I don't know, I was on the ground, and the next thing I know, I was on the sidewalk. That's a brain injury. That's at least a mild traumatic brain injury. Or if you have this hit or jolt or external force to the head, and you have an alteration of mental state. So it could be feeling really confused, disoriented. People who watch football, because this is the analogy that people are very familiar with in concussion, will see the guy, Tua, I don't know exactly how to say his last name, but he got knocked over. He gets to the ground and he gets up like this. People, they're like, oh yeah, wow, maybe he has a concussion. No, not maybe. He had a concussion. He couldn't stand up straight. He was clearly disoriented and confused, and he may have been out. We didn't get to talk to him to know if he was out or not, but he had a concussion. People see that and they recognize that. So when he seems all disoriented, people aren't thinking, oh, you're drunk or what are you up to? They know he had a concussion. But if you think of that same type of brain injury for a woman who experienced it by her partner behind closed doors, you don't get the benefit of the doubt that that's a concussion. It's often this other way around, that this woman just looks like an unreliable historian. So if you have a hit, a jolt, or external force to the head, and you have any focal neurological deficit that may or may not be transient, so it's like a visual disturbance, that would also be classified as at least a mild traumatic brain injury. So it's not that hard to sustain one, but they are meaningful. When I first started doing this research, I had a sample of 99 women, and I looked at the prevalence of brain injury in women who'd experienced partner violence. And what I found was that most of the women in my sample had sustained at least one traumatic brain injury from their partner. This 42M represents the 42 million women in the United States who have experienced past physical or sexual partner violence. If you go by that 1 in 3 estimate, that's 42.3 women. That's way too many. And I found that about 74% of the women in my sample reported at least one brain injury from their partner. If we were to extrapolate that, which is not epidemiologically correct, I'll just say that right off the bat. But if we were, that could be 31 million women in the United States alone who have sustained brain injuries from their partners. What's even more disturbing is that over half of these women reported repetitive brain injuries from their partners. Some, it was Well, it was two, three, 4, 5 times. But for some women, it was simply too many to count how many brain injuries they had sustained. If we're going to extrapolate that, that would be over 21 million women in the United States alone who walk around with probably undiagnosed, untreated brain injuries, repetitive brain injuries. This is not trivial. Now, we can say this was a sample of convenience, so maybe I've overestimated. Let's cut that in half, cut it in quarter. We'd still have 5 million women with repetitive brain injuries. There's no reason we should not be studying this. This should not be something that people are saying, oh, what's this all about? I also found that IP-related brain injuries were associated with poor cognitive and psychological outcomes. The higher, we created a brain injury score based on number, recency, and severity of brain injury, and higher brain injury scores were associated with poor performance on tests of memory, learning, and cognitive flexibility, and higher ratings of general distress, depression, worry, anxiety, and traumatic stress. So doubly bad if you've sustained brain injuries from your partners. It was not accounted for just being in an abusive relationship. We controlled for that. And for the cognitive data, we controlled for potential effects of psychopathology or substance abuse, and that could not account for these findings either. There was a link between the brain injuries and these outcomes. We also did a similar type of study in Colombia, South America. And we found that the prevalence of IPV-related brain injuries in Colombia was lower, around 31%. But I'm not going to say I think that this means brain injuries occur less in Colombia. We don't know exactly how this study relates to one to the other. But that's still a high number. Say 31% of women in Colombia are sustaining brain injuries because IPV there is even higher. Okay, and we also found, similarly to what we found in the previous study, was that higher brain injury scores were associated with poor performance on tests of both long and short-term memory, as well as tests of cognitive flexibility, and with borderline trend levels of higher ratings of depression. Now, we don't know what cultural influences there were here, so I'm not trying to say that there's a difference between US and Colombia. I'm not making differences. I'm just stating 2 different papers. I just want to make that clear. The bottom line here is that we see negative outcomes related to brain injuries in, not just the United States. And Canada has found similar findings, et cetera. And similar, we controlled for some issues here as well, and we found that the link between brain injuries and these outcomes were not accounted for abuse severity, STS, educational status, or substance abuse. And in another paper, I just like to remind people of one thing, and this basically talks a little bit more to the lifespan of women who've experienced partner violence. We know that women who experience partner violence often are an increase, they have a higher likelihood of having experienced childhood abuse in their past. And so one of the questions we raised was, is it possible that child abuse is contributing to some of the neurobehavioral symptoms that are being called post-concussive symptoms? And what we found was that was actually true. So childhood trauma in this paper we published earlier this year was associated with somatic and emotional symptoms independent of brain injury, but brain injury was associated with somatic and cognitive symptoms independent of childhood trauma. And the reason I'm saying this is not to say, oh, so brain injury isn't as important. I'm saying brain injury is definitely important. We see that again here. But we also need to understand that once we have a brain injury, there may be precipitating factors that make the post events of those brain injuries even more severe. And for women who are experiencing partner violence, we know childhood abuse is more likely a problem. So brain injuries may have even more negative outcomes for these women than women who don't have basically such bad past histories. Oh, and post-traumatic stress partially mediated the child effect trauma in that first, with the relationship between somatic and emotional symptoms. So it is a little complex, but nonetheless, we've been able to find direct links between brain injuries and these negative outcomes. So I'm going to spend a few minutes talking about brain connectivity. We use MRI to measure brain connectivity, just like we use MRI to look at a focal problem, right? If somebody has a stroke or whatever. And we talk about structural connectivity, which is just dealing with parts of brain cells that connect different brain regions, right? The axon, to be specific. And we can also talk about functional connectivity, which really just addresses or relates to regions of the brain that are working together, but are not necessarily right next to each other. And I'm going to talk about this a little bit more in depth, but the bottom line is we know that both structural and functional connectivity are critical for optimal behavior and optimal function. In the olden days would say, oh, somebody has, they were hit in their frontal lobes and they have a frontal, they have a hematoma in their frontal region. And so, oh, this is a problem because it's frontal, right? Or the frontal lobes do this and the occipital region is for vision, or, they had these dichotomies almost, well, not really dichotomy, but specificity of function. But what we've realized now is that whereas that is true, the connectivities between these regions is incredibly important. And if we don't take those into consideration, we're missing a big part of the picture. And this is really important for traumatic brain injury because traumatic brain injuries involve injury to the brain cells that are critical for both structural and functional connectivity. And so specifically, and there are other reasons traumatic brain injuries affect other ways traumatic brain injuries affect the brain. But let's just take this one specific way. We have this neuron here, right? Here, I'm going to use this. And this is just a brain cell. And we have the cell body here, and then we have the axon. And the axon is the white matter in the brain, and it's long, and it's thin, it's microscopic. So when you have these traumatic forces to the brain, you can cause damage or tearing or shearing of those axons. And so if you have that, you can have that brain cell will have difficulty communicating with another brain cell, or maybe it won't communicate at all. And these are tiny, but white matter is throughout the brain. It's diffuse. And so one of the things that we talked about early on in terms of imaging brain injury, because if it was just a concussion, it was like, can we see anything? One of the things that people picked up on was it was easier to understand or see potential differences in the diffusion of the water and the white matter, or how the water moved inside this axon here. And they called it diffuse because it occurs all over the brain. These little tiny guys are all over the brain. Axonal because it's affecting the axon and injury. So if you think of it this way, that's how we can have injury to the brain that seems to have some really negative output. But we have a scan that looks great. We don't see anything on the scan. We don't have the technology yet to fully scan and understand what's going on in a brain injury, even though something is going wrong. So one of the things that we've learned in neuroscience more recently is that we have neural networks that need to work together for efficient cognition. And what I have here is two examples of neural networks that we specifically studied in women who had experienced intimate partner violence. We have the salience network on the left, and we have the default mode network on the right. And the salience network is a network that if you were to put someone in the scanner and have them do a cognitively challenging task or really focus on some particular part of something in their environment, that network, you'd see those regions kind of get more quote unquote active, and they'd be active together. And that's kind of how we know that it's a network. So we call it the salience network. There are lots of these networks, by the way. The default network is a network that's interesting in one way because it is basically opposite to some of these other networks. So when the activity in the salience network goes up, the activity in the default mode network goes down. You can almost watch it, like it's really impressive to see how they can be correlated. So we know that what's also important in understanding cognitive in all functions is how these networks work together as well. And so what we looked at, based on a paper by Sharp and colleagues out of the UK, I hit two, sorry. We based it on a paper. What they did was they had a group of folks who had sustained brain injuries, not IPV. And they noticed that when they had people do brain injured and non-brain injured individuals do a cognitively demanding task. For the folks who were not brain injured, when they looked at these two networks, they found that when they were doing the task, the interaction or the connectivity between this right anterior insula here and, I'm sorry, this is going to the wrong computer, right anterior insula here, and the default mode network would increase when they were doing that cognitive task. But the folks who sustained brain injuries, they were not seeing that same increase, right? So there wasn't an increase in activation between these two networks. the way they were seeing it for the other folks. So we said, can we see that same thing in our women? And so we actually looked at this and found that IPV-related brain injuries were associated with network connectivity, which was also associated with memory and learning. So I'm going to break that down. So what we saw was that right anterior insula from the salience network was showing a negative relationship. The connectivity between that right anterior insula and this region in the default mode network was negatively associated with a woman's brain injury score. Okay, so the higher the brain injury score, the less these two networks communicated with one another. And the less these two networks communicated with one another, the harder it was for a woman to learn a list of words that were read to her 5 times and remember that list 20 minutes later. So it's not just, I'm showing you these results and like, what do they mean? Well, I think we can all agree that memory and learning is pretty important for everyday functioning. We also looked at structural connectivity and found that IPV-related brain injuries were associated with structural connectivity in the posterior and superior coronal radiata. This was based on a study that was done in football players who had sustained repetitive brain injuries. And what they found was they looked at what we call fractional anisotropy. That is just a measure of the diffusion of the water in that axon that I was showing you earlier. You don't really need to know what it means. It's just the water diffuses a certain way or moves a certain way. And that is an indication of we don't want to say integrity. That's a word we used to use, but that's not, we'll just say cell health maybe. But what they found was that fractional anisotropy for the football players who sustained repetitive brain injuries was lower in these regions than it was for folks who hadn't sustained repetitive brain injuries. So it said if we relate the brain injury score that these women are sustaining to regions of interest, the superior coronal radiata, the posterior coronal radiata, and the posterior thalamic radiation, can we see a relationship there? And we did for 2 of the 3 of those regions. The higher the brain injury score, the lower the fractional anisotropy was in the superior and posterior coronal radiata. Okay. So this is just evidence of both structural and functional connectivity being altered in women who have sustained repetitive brain injuries from their partners. So next, I want to spend a few minutes talking about strangulation. And so someone might say, well, why are we talking about strangulation and then talk about brain injuries? Strangulation is a serious, horrifying form of abuse, and it can cause an acquired brain injury. Not a traumatic brain injury, but an acquired brain injury. Strangulation is not choking. Choking is when you have something lodged in your throat. If a woman tells me I was choked by my partner, that's fine. I'm not going to quibble with her. But as academics, we should always use the term strangulation. Strangulation is an external attack on the neck. And it can cause asphyxia, which simply means depriving something of oxygen, right? It can lead to unconsciousness, or if long enough, it can lead to death. And you can hear terms like hypoxia, which is simply partial loss of oxygen to the tissue, or anoxia, which is complete loss of oxygen to the tissue. That's all those terms mean. And so strangulation is a form of asphyxia from external pressure placed upon the neck such that there's an obstruction of either blood flow leaving the brain or blood entering the brain via the jugular leaving or the carotid going in, or an obstruction of the airway. That's, I'm maybe using the cursor on, I don't know if you can, I don't know if you can see the cursor. I'm going to stop using it because I don't think the cursor is working. But anyway, the trachea is in the middle there. Now, when I started doing this work, I thought strangulation was you're blocking the airway, right? I can't breathe because this thing here is being blocked, so I can't breathe. No, that's only part of it. And it doesn't take a lot of pressure. Someone can be strangled just by blocking the blood flow to the brain. If you block only the blood flow, I can't, without the cursor, it's hard. So the jugular veins are a little bit more lateral than the carotid, and the jugular is draining the brain, okay? If somebody puts pressure on that part of the neck, you may have a situation where blood is entering the brain, but not allowed to leave the brain. And then you have increased intracranial pressure, which can cause problems because you have blood going in a tight space, but nothing's leaving. Now, if you block both the carotid and the jugular, now you don't have that problem because blood's not leaving the brain, but it's also not getting into the brain. But now you have a different problem because now you have potential anoxia or hypoxia or ischemia to those brain cells. So via that mechanism, we have a potential acquired brain injury from strangulation. If, needless to say, if the airway is crushed, then you're not getting air, oxygen in a different way. So that can also cause asphyxiation. Blood buildup or lack of enough oxygen from strangulation can cause damage very quickly. Blood buildup can cause unconsciousness within 2 minutes. Anoxia can cause unconsciousness within 10 seconds. Strangulation can cause brain death in less than 4 minutes while leaving no external mark. So if somebody says, well, she looks fine, I don't think she was strangled, I don't see anything, hopefully everyone here can correct that erroneous statement. In one study of around 300 women, 50% of the women who'd been strangled had no visible evidence. If you do an angiogram or something, you might be able to see some internal damage to the tissue. But if you just look at somebody, you may see nothing. Damage may result in death days later. You could have swelling, a carotid dissection. This is pretty rare, but there are certain things that have been known to happen after the strangulation incident and that cause death. So strangulation is serious in a lot of different ways. The rates of strangulation and intimate partner violence vary depending on how it's measured, but it's high no matter how you measure it. If I just say, excuse me, did your partner ever choke you? We use that because it's a term used on the conflict tactic scale, and it's one that women understand. We have 86% in that sample of 99 women reported at least one event of being choked by their partner. If I ask it in a way to try to elicit whether or not an acquired brain injury may have occurred. So after anything your partner ever did you ever lose consciousness, feel dizzy, dazed, disoriented, confused? And they say, yeah. And they say, yeah, well, when he put his hands on my neck, when he choked me, 27% of the women in that sample reported at least one alteration in consciousness related to strangulation. And so in a paper published earlier this year, we also showed that strangulation-related alterations in consciousness were associated with poor cognitive psychological outcomes as well. Women who experienced alterations in consciousness from strangulation were more likely to have poor performance on tests of long-term memory and working memory, and high ratings of depression and post-traumatic stress. And this was not accounted for by childhood abuse. As I saw earlier, that was something we're taking into consideration more carefully, or the number of IPV-related traumatic brain injuries, because it's certainly the case that the women who are strangled are more likely to have high ratings of traumatic brain injuries as well. So we adjusted for that, and we still saw this relationship. And so when we talk about strangulation here, I didn't talk too much about the title of this talk, but if anyone noticed, I said concussion plus. This is the plus. And there's other things that can be the plus too. But I think when we talk about concussion, people tend to think of athletes or military folks. Maybe, a high injury, a sensation-seeking sport or something like that. But they don't think of women who've experienced partner violence. And if you do, you should think not just of the traumatic brain injuries that they're sustaining, but also the fact that they're sustaining something that these other groups don't sustain that can cause an acquired brain injury and potentially interact with those effects. And I would say probably make things worse, but strangulation. So when I think of women and their brain injuries, I like to think of a concussion plus, because I don't want us to forget that strangulation is very common in these women, and this can be causing other problems. And if we want to go even further, the plus could also be the incredible psychological stress that these women endure on a daily basis. I just want to take a real quick minute. I'm looking at the time. I have time. But I just want to say a little bit about COVID. Unfortunately, I said this, and then the other day I heard someone say this: COVID was an abuser's dream. Women are often trapped in dangerous and terrifying situations. This is the power and control wheel. I did not this is not my design, but this lists all the different ways that women can be trapped in abusive relationships. People say, why didn't she just leave? Well, gee, I don't know. He threatened to kill her. And 3 to 4 women a day are murdered by intimate partners in the United States alone. And the most likely time for someone to be murdered is once they've said they're going to leave or after they've left. So it's not an idle threat. They can use children. They can threaten to kill the dog. They have often by this time financially and socially isolated, basically financially made the person, quit their job, or they may have. All relationships are different, but there are so many different ways that abusers control their partners that to say, why doesn't she just leave, is a horrible question to ask. Why does he keep beating is the question we should ask. At any rate, we have someone who's already trapped, then we have COVID, and so we basically trap them even further. And so IPV really represented a clash of 2 pandemics, likely resulting in increased levels of brain injury. We know because we saw the evidence come out. People were looking at IPV as COVID went across the globe. You could see rates of IPV escalating, right? No one's studying brain injuries because that's not what we do, right? People aren't thinking of that. But I can guarantee you that the brain injuries were going up as well. But we have the economic stress and uncertainty, loss of jobs, fear of contracting the virus, the COVID mitigation strategies. You have to spend more time together. Anytime families have to spend more time together, there's an increased likelihood of violence, even on the holidays. So now we're stuck together in unhappy times. So then the women had no place to escape, no place to call for help. By the time they left, they had more severe injuries. And there's evidence of that as well. So rates and severity of IPV were increasing since COVID-19. That has not gone down, by the way. We have homicide rates escalating. The numbers there are really horrifying in many countries that I looked at. And ultimately, the bottom line is COVID mitigation strategies, which are appreciated and I think are good. I don't want to say that I think they should not have been in place, but ultimately for women, it basically reduced women's ability to escape violence and leave the situation. And we know that historically, whenever there's been a crisis or some type of horrible event, the demands for IPV services have gone up and stay up at least a year later. So this is not going away soon. This is a crisis that has gone on for a long time, still is not really over, and the economic effects are still being felt by many people. This is a story, given the time, I won't go through it, but let's just say that this woman in Uganda was stabbed, lost consciousness. People had to bring her to the hospital. And in the story, they talked about, and this was COVID related, but I'm giving a short version, but they talked about her recovery from her eye injury, et cetera. And I looked and read it several times. Not once did they mention anything about a potential brain injury. And you can see if a woman comes in and she's bleeding out of her eye, that's what we think of. But nowhere in the story said she's recovering, she may have a brain, so it's just seriously overlooked. So what can we do? I've given you all this, unfortunately, not pleasant information. Sorry, I said I can't sugarcoat it. I said this isn't a fun topic, but we need to talk about it. But what we do, start the conversation, especially with respect to COVID. One of the things, if we want to call it a silver lining, is it provides an opportunity to interact with people, to ask about partner violence in a way that may not be insulting. So one of the things that we could say is, I know that COVID has made it really difficult for a lot of family members to get together. There's been a lot of stresses. And I just saw this talk and it said, we don't know if partner. So I'm just checking with all my friends. I don't necessarily think it's you, but it happens to a lot of people. And I just wanted to check. Are you safe? Is everything okay in your home? That at least gets the door open to IPV. And then from there, we can go to this next step. This article is one I wrote because there were tons of articles coming out after COVID about the increased rates of IPV, but nothing about the increased rates of potential brain injuries. Just wasn't being asked, wasn't being considered. So I always tell people to keep in mind the high likelihood that IPV-related TBI or strangulation may have occurred. You want to see have the right questions been asked because a woman will not necessarily know that she sustained a TBI, and a woman may not recognize the relevance of reporting that. If she can get up and walk away and can, show her face at work, okay, I'm good to go, right? But if she has a broken leg or a broken arm or is bleeding, she's got to go to the doctor. Brain injuries have a way of being invisible and staying invisible in really unfortunate ways. And a negative scan does not mean that there's no brain injury. In fact, if you have just a standard mild traumatic brain injury or a standard concussion, you will not see evidence of it on a scan, not any like regular scan anyway. So TBIs unseen behind closed doors are likely to be misinterpreted or missed. So someone, say you're a police officer showing up at a domestic violence call, and you see a woman who looks disoriented, confused, distractible, inconsistent. Maybe she's saying she has a headache, she's uncooperative, kind of belligerent, dizzy and off balance. Wow, this woman's been drinking. This woman is clearly, and the partner's over there giving a straight story. It's all verbal. There was nothing that happened today. She's like, no, it wasn't. He hit me. Well, you just said you were in the bathroom, but you were in the bedroom when we showed up. How did you get from one place to the next? She looks like she's a very unreliable historian. Now, I don't know what happened, but it certainly could be that he did hit her in the bathroom. She passed out and he dragged her into the bedroom to get her into the bed. So it would look like she was sleeping when the police officer showed up. She has no idea how she got there because she wasn't awake for it. Or maybe she has post-traumatic amnesia for it. So if we don't see a brain injury occur, we are most likely going to make a negative assertion about what happened unless we change how we think about IPV and always entertain the idea that maybe a brain injury occurred. And just because I see beers on the table or some drug paraphernalia doesn't mean she's just strung out or drunk or whatever. Let's find out what's really going on here. Because what that law enforcement officer writes down in the notes is going to make its way down the chain, potentially to the judicial system, et cetera. It's going to have serious ramifications for children, for restitution, et cetera. So TBIs can make it harder for women to survive, escape, or keep her children. It may make it harder to assess danger and defend herself against further abuse, i.e. get out of the relationship. Make it and remember safety plans, go to school or hold a job so she's remaining financially dependent on her partner. Leave the abusive relationship and live on her own. If you've been sustaining repetitive brain injuries, it may be really challenging to feel like you can do this. You can get out safely without getting murdered and then live on your own when maybe you haven't had resources to begin with. And then it may make it harder to access necessary services like adaptive living in a shelter. Shelters, you come into a shelter and you have a list of things you have to do. You may have to get an order of protection. You may have to find a school for your kids. You may have to start to find housing. You may have to apply for a job. And just getting an order of protection may have 20 or 30 steps. So you tell a woman to do all these things and you send her into a shelter with all these bright lights and commotion and loud screaming kids. And then you think she's just not working out because she comes back a week later with nothing done. Well, if you just sustain a brain injury, that's an absolute nightmare situation to think it's going to go well is not reasonable. And so ultimately it may make it harder to retain custody for children as well. But why do I say a lot of these things? I want to emphasize that having a brain injury does not mean a woman is unfit. So there are some people who are saying, and I will say, unfortunately, the judicial systems, at least here in Canada, are not set up so that women are protected. Usually it's just the child is the one we care most about. And I don't understand the logic, but literally if somebody gives a woman a brain injury, and then he says, well, I've taken anger management classes, but she has a brain injury, so why should get the kids? I had a judge tell me, yeah, that would fly. And, that kind of blew my mind. But so what we need to say is, it does not mean she's unfit. There may be other things that make her unfit, but this should not be an assumption. That should not be something that's used. And there may be cases, and I'm not talking to lawyers here, but if I were, I would say you may not want to share that information with the courts. But the woman should know, no matter what. I think women should know if they've sustained brain injuries because that's impacting their function in a myriad of ways. You may not share that information if you think it's going to hurt in court. So there's dynamics here which we need to navigate, but nonetheless, it does not mean a woman is unfit. And so the next couple of slides really just talk about interacting with women in a way that's sensitive to the possibility of a brain injury. These are not necessarily specific to women who've experienced partner violence. These are ways to interact with people who've sustained brain injuries. So minimize distractions, be in quiet locations, have short meetings or take breaks, avoid loud noises and bright lights, repeat information. If you think of these things, you can see how a lot of this probably does not usually happen for women who are experiencing brain injury and trying to get some type of assistance. But prioritize goals, make them smaller steps and break them out, talk slowly and to the point. So I would not talk this quickly to someone who I may think has repetitive brain injuries. I'd be much slower and I would be constantly checking in with her. Double check to be for sure that she's understood the information. And then just a few more. One task at a time and stick to the task at hand. Be factual and concrete. Allow extra time or help her complete tasks. And these are things that I write out because anyone can use them. And for shelter advocates, some of these have been incredibly useful. Point out possible consequences of decisions she may need to make. Provide respectful feedback on problem areas that affect her safety if she thinks she's functioning better than she is, and encourage self-determination and identify strengths. These last three, I think, are really, really important. Because if you there's so many things that are going on with people who have experienced partner violence, or if they're currently in the situation, especially, and if they've sustained brain injuries. So they may not think, they may think, oh, I can do this, and this will work. And if it's not a good idea, and as you can see this, just don't say, well, that's a bad idea. Say, well, you could do that, but if you do that, this is likely to happen. But let's see, what can we do? What are your strengths? I'm telling you, the stuff I have heard, for example, from Lily earlier, what she endured to come out on the other end and being where she is now is truly phenomenal. These women have strengths. There is no doubt they are stronger than a lot of people, or maybe most people I know. So we have to find those strengths, and then we work with those. And so who should know this information? Well, if it's not obvious at the end of this talk, I didn't do my job. I think absolutely everybody, judges, lawyers, EMTs, nurses, the women themselves. Women don't recognize necessarily that this is a problem. Lily, I don't know, it was 20 years later or whatever, she saw my paper and she was like, oh my gosh, now I understand. Yeah, I had sustained so many brain injuries and now so much in my life makes sense, right? But she didn't know before that. First responders, for the reasons I've illustrated through this talk, police and paramedics, judges, again, for reasons I've illustrated through this talk, and IPV support staff. A lot of women have said, we don't feel like we can, I don't know what to do with a brain injury, but it's not that hard. You may not, as somebody, we're not asking people to diagnose brain injuries and to give some official diagnose or to take some course, but just find out if she's lost consciousness from something, from some impact to the head, or she's lost consciousness from being strangled. Well, she may have sustained a brain injury. There's simple ways you can at least get an idea and then say, okay, do some of her behaviors fall in line with what we might call post-concussive symptoms? Is she having certain problems? Maybe that's what it is. I really think that every shelter should have a neuro rehab unit right next to it. It should be built into the shelter. Hopefully one of these days, that's kind of my dream. And so I just talked about this. Women don't necessarily also understand that it may be influencing how they behave. They think, well, he hit me in the head, but I'm fine, right? I got up, but maybe, but you may have, sustained some type of injury that is decreasing your ability to function the way you really should be. Including the ability to escape their abusive situation. The woman who escaped, it was not easy for her. In fact, she had to wait for him to be away, and she left in the middle of the night. It was a secretive thing. I mean, it's not always easy. And then this is one of the big questions of the hour. People are talking about CTE and football all the time. I don't talk about CTE here because I don't want women to say, here I said it because we're all academics, but I don't want to go into a shelter and say, oh, we're afraid these women have CTE. We don't know that. But there are 2 cases where women who had experienced severe head trauma from their partners have been shown 2 case reports of CTE, but we don't have any studies that have looked at a number of autopsies of women and said, oh yeah, a lot of these women have CTE. But the idea that they may sustain effects that are going to result in later neurodegeneration at an earlier age than they should, I think is an incredibly reasonable idea based on the women that I've seen before. We need the resources, we need the people, we need the money to do this work. But it just hasn't been done yet. I mean, I applied for something, but didn't get funded, but I'm not going to give up. But ultimately, we're in the early stages. I'm hoping that this will come. But ultimately, I just think that we know so little about the long-term effects, what's going on here. And so I just want to end on a positive note. It's like, this is such a heavy topic and it's not fun. It's like nice to make jokes and have, something like that when you can do that in your lecture, which I really can't do here. I don't think it's appropriate. But I do encourage people to create opportunities to inspire empathy and action in the next generation. Well, it could be in ourselves, but if we don't have time, look to our youth. We have to train our youth better, et cetera, and then provide opportunities for them to learn about this topic and maybe do something because it can make a difference. I'm just going to show 2 quick little examples and then I'll be done. My niece, who was 13 at the time, knew what I was studying, and she's very crafty. And so she liked to make bracelets. And so we talked about it and we came up with this idea of creating a program called Beads for Hope. And so she would make these bracelets. No 2 are the same. And she buys the materials, puts them all together, and they come in this little bag. Actually, I have some here. I didn't know if there'd be an opportunity to hand them out. I'll tell you that in a second. But hold on. Oh, that's an empty bag. So they come in a little bag, and it has a note that says, hola. Well, it's translated into Spanish, French, and English because that's where I've passed these out. But it says, hello, my name is Veronica, and I created this bracelet to remind you that you are deserving of beauty, recognition, and hope. And whenever I give a lecture, I have some of these, and anyone who is a survivor, anyone who's experienced partner violence, doesn't have to be a brain injury, just a survivor, or knows somebody who's experienced partner violence, can take 1 or more for free for each person that, is a survivor. And if it's a survivor with children, you can take 1 for the children as well. And so that program, I don't even know how many years it's been now, but is she a sophomore at Princeton now? So basically it's been going on for a little while, and now her sisters are working on it, and I'm about to bring some over to London. And I've literally had an exchange where I met a survivor 1 year, she got the bracelet, and a year later I saw her and she was wearing the bracelet. And I had research folks, I had a research participant tell me, like, I made her year. And it was like a simple thing can be so impactful. And then this is actually my kid. He's 11 now, but he was probably 8 or 9 when he did this. Their class was doing a fundraiser, dimes to dollars. And they were just supposed to probably make like $30 or something like that. But they had to find a fundraiser. And he said, I want to do it for pain concussions because women should not get beaten up. Women should not get hurt. And my mom is part of this organization. And so I want to raise money for this. He ended up raising over $300 for this cause. And then he presented to the partner inflicted brain injury task force that we have every last Tuesday of the month. It's an international meeting, but he set up his Zoom, et cetera, and presented and told about this. So these are just simple little things that people can do, and they do make a difference. We're not going to eradicate IPV anytime soon. And so we're not going to get rid of brain injuries anytime soon. But I'm doing my darndest to help in that way. And there's other ways people can make simple positive impacts. So with that, I will just say IPV-related brain injuries are very common and dangerous. And I really believe it's our job, it's our ethical responsibility to recognize these and intervene. And there's my email for anyone who wants to be in touch. Thank you. Oops.
I have some questions on Zoom. Does anybody in the room have a question? All right, I'll start with,
To explore what we can do as clinicians that's effective and feasible for patients coming through our services. We know that the rates are high.
So, the question is, are you so for assessing for partner violence or for brain injury? Because there's 2 levels. I think for partner violence, sorry, I don't know if that's my computer. for that dinging. I mean, it must be because I don't know what else, but apologize. For partner violence, I think that so the WHO doesn't necessarily recommend universal screening. But I would say if there are any indications, I personally don't find it offensive to ask. And if you say, I ask everybody this, you can, some of the questions that I've been asked are, do you feel safe at home? Or if there are signs, if the partner is, sometimes a doting partner can actually just be a very controlling partner. They drop her off everywhere, they pick her up, and that's so she doesn't leave his sight. But if there are signs, if she comes up repeatedly with weird injuries or has, it doesn't seem happy. Obviously she may not seem happy, but you can just say, are you safe at home? We know that intimate partner violence is very common. It happens to a lot of people. And so we just ask, are you safe? And then if you find out that violence is going on, it might be, you could refer them to, there's the National Domestic Violence Hotline, and there's local shelters. There's a number of different resources. You'd want to be set up with this, right? But you can refer them there. And then we can also, if you want to go the step further, you can potentially try to determine if they've been hit in the head. And depending on how that goes, we don't want to be, one of the things that's interesting is because I feel like some people say, well, we don't want to scare people into thinking they have a brain injury, but I have yet to have someone come to me and say, oh, somebody was really afraid because all of a sudden I thought they had a brain injury. I think if anything, they recognize, my brain isn't working. It's almost a relief. So it's interesting because I don't want to say anything 100% one way or the other, but overall it's been a welcome knowledge to recognize this if it's presented in the right way. Because a brain injury does not necessarily mean anything negative. You've sustained that brain injury. That's done. That's over with. Or you've sustained those repetitive brain. It's done. There's nothing you can do about it. But if you're living with potential consequences, now you're in a position to try to deal with it. Right now you can say, okay, well, this may be related to brain injury. So what can we do? And we go to neuro rehab and we figure out what we can do. They can be referred to the right specialist who may then be able to help them. So sorry, it's a little long and there'd be a lot of training involved. So I don't want to say too much, but yeah, I think recognizing it is the first thing.
So we have a question from Dr. Sheldon Benjamin, who's a neuropsychiatrist and our vice chair for education. He wanted to thank you for a wonderful presentation. Both the content and the visual aids were masterfully presented. I would agree. Here's his question. What work is underway to alter the protocols used in emergency rooms and police stations after IPV comes to their attention, and to add a TBI evaluation or referral to a local concussion clinic as part of the routine? In our neuropsychiatry clinic, for example, we very seldom get referrals for brain injury evaluation due to domestic violence. Yet with motor vehicle accidents, we see many people alleging TBI-related deficits. And he suspects this relates to the orientation of our system toward victims' compensation in motor vehicle accidents, but not IPV.
So that's an excellent question. And that, I think it just goes to show that we're not appreciating we're missing a huge segment of the TBI population. What is being done? There has not been a lot done. And I am working with a few people who are actively trying to change protocols with law enforcement. I know many years ago, it's actually California was one of the leaders in this. I worked with a police force, and we did actually include in their protocol what they're supposed to say when they show up at the scene, some questions about alteration in consciousness, and followed it up with if it was A to the head. So that was one of the things that we did. Now, is that being done universally? Absolutely not. Will there be resistance? Maybe, because people don't want one more thing to ask about, or maybe they don't believe it or understand it. But I think that's where we need to be. We need to be understanding that. And one of the ways I think we get buy-in, because it's also with shelters, it's like, oh my gosh, I'm overwhelmed. Now I need to be a neurologist too. It's like, no, we're trying to make your job easier, right? So if we frame it that way, the idea is if you're working with somebody who sustained a brain injury, but you don't recognize it as such, you're going to go down certain paths that are probably not going to be as pleasant, right? She's going to be combative or combative. Maybe she won't be telling the right story. So now you have two different stories. But if you recognize that a brain injury has occurred, then you say, oh, okay, well, yeah, she's maybe exhibiting some post-concussive symptoms, or, at the door of a DV scene, understanding that, oh, that might be why she doesn't remember. She's not necessarily lying. Now, I can't say one way or the other. It's behind closed doors. No one's going to know except for those two people. But if you don't entertain the idea that a brain injury has occurred, it's certainly not going to ever be considered in the long-term run. So there are groups who are working towards trying to modify protocol for police. And there's actually one thing that I'm actually really eager to learn more about. I was just invited to give a couple of lectures out there in Bend, Oregon. And they're using, and I'm not advocating this because I don't know anything about it yet, but they're using a device. I'm guessing it's testing something like near point convergence. I forget, but they're looking at the eyes. And I think the idea is to give it to police officers. So if they show up at the scene, they can have a woman do this and put this on their heads. And again, I just learned about this like this morning. And it's, I think, predictive of whether or not you've sustained a concussion. So there are things that are being considered that might be easy to, implement in these types of settings. But we need to do more.
And just one other question. Dr. Andrew Stone adds that there's a similar absence of evaluation for TBI for people who engage in significant head banging. This would require the protocols being added to the psychiatric evaluations in both inpatient and outpatient settings.
Agreed. I know less about head banging. I would hope that people who are studying head banging would consider that a brain injury may be occurring. That seems a little, I don't know. It seemed obvious to me that brain injuries were occurring in partner violence, and it's not obvious to everybody. But I agree. If someone is headbanging, yeah, we absolutely should find out if there's alterations in consciousness. And there, going a step further, if you look at the work that's been done in males in football, American football, it looks like it's not necessarily concussions per se, but subconcussive hits that may contribute to long-term negative outcomes. And so there, I don't know what the force is for head banging relative to the force for the football that they're studying the football players, but could those subconcussive hits be relating to something later on, even if it's not technically a concussion? I don't know, but I certainly would encourage, try to tell people if they're hitting their heads that we don't know what the long-term effects are. But I'm not sure that's necessarily a logical thing that people do. I don't know that much about that.
Thank you for your talk. This question is about COVID. Do you know if there's any work done that has been done screening women who report neurological sequelae of COVID for IPV?
I don't. My guess is, I think that overall IPV is underappreciated and understudied and underasked about. So is there a program that I know of? No. Should it be done? Sure. I think overall, when we have people in our practices, I'm not a practicing clinician, but I think that should always, if you think of the high prevalence of partner violence, now 1 in 3, that doesn't mean that they're experiencing it right now. So if you're seeing, 3 women, it doesn't mean right now they're experiencing partner violence, but at some point, so they may have had it in the past, but that's still a high number, high enough, in my opinion, to be asking people pretty consistently, are you safe? This is a really prevalent problem, and we just want to make sure it's not contributing to what's going on here, right? So going the other way around, I would say that we just need to be asking more. We need to be thinking of intimate partner violence more and not being afraid to talk about it or offend somebody if we ask them about it. And I'll just say, I know this is the end, people probably signed off potentially, but I talk about women and really largely cisgender women because that's who I've been able to study so far. Partner violence does occur to men as well, but men are not good, or they don't get hurt as much, physically injured as much. And it is a lower prevalence rate. But I don't want to say that we should ignore partner violence to men either, because that's a serious issue too. But I don't have any data on men. And I'm actually starting a study to look at transgender women, but we don't really have any data on IPV related brain injury in transgender women as well. But I suspect it's going to be at least as high.
Well, thank you very much. This was a fascinating talk and a lot of education for all of us. Thank you.
Thank you. Thank you for having me.